नहीं है।
Hello everyone and big thank you for being here today. I am Saxena along with my colleague Dr. Deepika Chabra from Medical Services on behalf of Jagsonpal Pharmaceuticals Limited Pharma Division would like to extend warm welcome to this Scientific Sangam 26 organized by ISOPARB Prayagraj in association with AMOGS, Meerut and Allahabad Obst and Gynae societies and academic partner Jagsonpal Pharma Ltd, makers of Divatrone injections, Maintane and Divagest. Please note this webinar is granted 3 ICOG points. We would like to present Divatrone 10 mg tablets, fully indigenized, micronized dydrogesterone, the only brand having 36 months of shelf life. Jagsonpal would like to thank the experts and attendings for joining us today through this webinar, The Final Push, the Art and Science of Birthing. Dear attendees, if you have any questions, suggestions, clarifications, please post it in the chat box. We shall also enable audio of attendees to speak up and make this webinar more interactive. So please raise your hands if you wanted to speak up. Please note this webinar is streaming live on Facebook and the link is already shared in the chat box. For this, today's final push, the art and science of birthing, I welcome organizing chairperson, Dr. Ranjana Khanna ma'am. Ma'am is founder president ISOPARB Prayagraj. She is also ICOG governing council member, vice president Foxy 2017. Ma'am, I request you to please kindly initiate this session. Thank you.
A very good evening to everyone, and my respect to Dr. Usha Sharma ma'am. And first of all, before beginning any program, I always pay obeisance to Lord Shiva. So please. A very good evening. Today, I heartily welcome all the faculty and the delegates to this very interesting webinar on the final push. Today, we are blessed to have esteemed faculty from 2 states, important states of India, that is Maharashtra and UP. So we have the Maharashtra Association of OBGYN societies with us, along with Meerut and Allahabad societies. We are also very fortunate today to have with us as chief guest, founder, president, and chief patron of UPCOG, Padmashri, Dr. Usha Sharma ma'am. Ma'am is a dynamic lady. I think all of us are familiar. She's a revered teacher and a powerful orator. I think she's the, the female equivalent of Dr. P.C. Mahapatra. Her ever-smiling countenance gives a lot of strength to her innumerable students. She received a leproscope from the hands of one person whom I admired so much, Srimati Indira Gandhi. Her aura and charisma are there for all to behold. As guest of honor, we are pleased to have a very good friend, Dr. Rajendrasing Pardeshi. How much I had troubled Dr. Rajendrasing. I used to continuously meet him in all the managing committee meetings and say, I want to come to Aurangabad because I want to do darshan of Krishneshwar. And he would all the time invite me. Ki, ha, you're most welcome. Come. But somehow I could not make it. And then finally he gives me a call and says, now we are having the annual AMOGS conference at Aurangabad. So you are invited as a faculty. Please come, deliver your talk and also do your darshan. So that was a very memorable event for me because I really enjoyed the conference and the darshan and the visit to the Ajanta and Ellora caves. It was all so beautiful. As speakers, I have brought together all the three candidates who are contesting for the post of Vice President West Zone Foxy. And all three are wonderful speakers, very dynamic, and all are my very dear friends. So all the best to all three of you. And it's up to God who wins, but all three of you definitely deserve to be the vice presidents. And the fourth speaker is our candidate from North Zone, our very, very dear and dedicated and active Foxian, and that is Dr. Bharti Maheshwari. So it's a request that all of you please do support her. And we have some wonderful chairpersons. From Mumbai, we have Dr. Sujata Dalvi. She's the secretary of AMOGS. And we have Dr. Kiran Kurtukoti from Pune, and Dr. Usha Sharma and me were just remembering his wonderful vote of thanks in Sunita's conference at Pune. He is so good, so innovative a speaker. So we haven't forgotten him. And we have our my very dear friend Kirti from Meerut. She's my batchmate. And we have Priyanka, the upcoming and star of actually UP she's becoming. And we have Dr. Archana Goyal, and we have our own ISOPARBians and AOGS members, Dr. Urvashi, Dr. Chitra. So, and I cannot forget.
And what about your name?
I cannot forget one person who is such a dynamic convener, and that is Dr. Amita Tripathi. She is the founder secretary of ISOPARB Prayagraj, and she has been always with me through thick and thin. And besides Amita, we have as co-convener Dr. Uma Jaiswal, and we have as communicator Prayagraj, my daughter-in-law, Dr. Parul Khanna. Ma'am is, as I've said, she's Padmashri, Dr. Usha Sharma, ma'am. And she has been the ex-Director General Medical Education, Uttar Pradesh, Principal cum Professor of Gynae and Obstetrics, LLRM Medical College, Meerut. I think Meerut has always been synonymous with you, ma'am. And she has got lifetime chief patron of UP chapter of Obst and Gynae. She was the founder president and patron of Meerut Obst and Gynae Society, and distinction in so many subjects and outstanding awards. She's been Padmashri, and she's also got Dr. B.C. Roy National Award. Yes. And Indira Gandhi Priyadarshini Award and Jewel of India Award, and ma'am, so many awards and so many and orations. I remember how I requested you for giving an oration for Sevma, and then you said, "Ki nahi beta," but you know, you captivate the audience when you speak. So ma'am, over to you, and we want your blessings for this webinar.
Thank you so much, dear Ranjana. You have really said such wonderful words that I do not know whether I really deserve it or not.
Of course, ma'am.
You all are like my own family member, and I thank you a lot for that. Organizing chairperson of this wonderful webinar, Science and Art of Birthing. And I will just now tell you about the story of this push and pull. That is a different thing. But it is the series which is really needed these days. And we really want to know about the second stage of labor. So Ranjana Khanna is a very good organizing person. She has organized this. And then we have guest of honor, none other than Dr. Rajendrasing Pardeshi. Everybody knows he is President AMOGS and a wonderful person. And then we have convener, as Ranjana said, that मैंने तो हमेशा अमीता को ही convener देखा, and she is such a nice that she convinced the meeting so nicely that I really admire her this capability. Then we have with us co-conveners Uma Jaiswal and Parul Khanna, and we have four learned speakers, sorry. Three I just remembered because just now we were discussing that all the three are contesting for the this West Zone Vice Presidentship. And as Ranjana said, and I was telling Priyanka just now, it is not the examination and election of the candidate, but it's a real examination of the voter. Whom to vote, it is so difficult to choose between these three persons. All the three persons are so competent, so capable, so learned, so loving, so affectionate. You add any distinction or any quality and they deserve it. So it's very difficult, but election is always a game, and I should take that. I always say that everybody should take it very sportingly. It is not life and death. It is 1 year job which goes to, and everybody can be by rotation, whether it is Komal or it is Varsha or it is Sneha. So all the very best to you, all the three. And then the fourth speaker is no doubt is my right hand of the society, as the Priyanka is left hand of our Meerut society and Bharti is the right hand of our society. And of course, the only thing which I will like to mention, that not because she is right hand of my society, but actually she has really worked a lot for the Foxy. And that is why I always say that don't go by the name, but go by the merit when you are selecting or electing or voting for anyone. So let us all see what happens in the election, but all the best to all the four speakers for their incoming elections. And then we have got such wonderful chairpersons of today. The first one, of course, is our beautiful, ever-smiling Ranjana Khanna. And then the second one, my dear young, dynamic Priyanka, who is secretary of our society. And the next one, next pair is the Sujata and Chitra. And after that, we have Kiran. Abhi hum iske pehle discuss kar rahe the that Kiran, have you arrived or not? नहीं, अभी तक नहीं आया शायद किरण. रंजना, किरण आए कि नहीं?
अभी नहीं, I don't think so.
We were just thinking, जब किरण ने पूना में अपना vote of thanks दिया, तो सब लोग सोच रहे थे उठ के चल दो. But as soon as he started vote of thanks, he mesmerized everyone, and everybody just खड़े पे सब बैठ गए कि भाई ये क्या कह रहा है. And then we were not ready to accept the end of vote of thanks. We were just wanting he should continue. Such a wonderful person, and of course he will be coming just now. And then along with her we have a very new, competent and upcoming person from Meerut, Archana Goyal, who is secretary of ISOPARB. And we have got then Kirti. We know that she is a very strong pillar of UPCOG and has taken the responsibility of secretaryship for so many years. And she was just now president. Now Bharti is president of our society. And along with Kirti, we have Urvashi. This evening, we are going to have a series of the webinar which Ranjana started, and I will say it was very thoughtful for her to start this seminar, which is really very, very important and very practical and very fruitful in our day-to-day practice, science and art of birthing. You know, second stage of labor is very difficult. And everybody takes it as a, oh, second stage ho gayi, kitte ghante nikal gaye, kya hua, how many hours have passed. And there is always a push, there is always the adrenaline secretion, and then the patient lying on the labor table, she is always trying to push hard so that something comes out. And not only the patient, but I will say even the clinician is very panic and really in stress. But the things have changed now. The scenario has changed. Nowadays, we do not say push, push, push. We say be patient, be calm, be quiet, and everything will be good. So now the things are very, very much different. And doctor and patient both are asked to be calm and quiet, because there is lot of difference now. Now we know that this continuous monitoring is extended up to the second stage of labor. And even the guidelines of labor, they also say that the CST tracings are available for second stage of labor. And so many times it can be more than 2 to 3 hours, or even more in a patient whom we are giving epidural analgesia. And so these things are not just to be very much worried. And because we have seen even second of a stage of labor prolongs for 4 to 5 hours without any problem. And so we should, when we have the facility of continuous monitoring, then we should not push up much. We should try to be, because our aim should be to get the baby vaginally, delivered vaginally. We know that with the increased incidence of cesarean section, they have its own associated complications. And that is why these days, WHO, FOXY, FIGO, and ACOG all have recommended for vaginal deliveries, not the cesarean sections. And so we should also join our hands that we should also try that we should go for vaginal delivery. And Ranjana, I will really like to congratulate you to start this series in which you have so emphasized so much, and everybody has been, I can say that they have been trained and they have really found out the importance of normal vaginal delivery. And they have really made us feel that the hidden esthetician which was in us should come out. And then we should feel proud when we get a delivery vaginally done and not the cesarean section. I tell you, when I was lecturer, at that time, cesarean section was not that common. And I tell you my own story that one of my patient, he was very close to me. I never used to do private deliveries, but he was so close, like a family member. I had to do it. So he was in the nursing home, her wife. And then when I went there, first, I saw one maternity picture, evening picture. Then I saw the second series of that picture, and she did not deliver. And then the next morning she delivered, but I had to watch and wait with the monitoring of the fetal heart. At that time, we did not have such sophisticated instruments. But I tell you, when she delivered in the morning, normally, I can't tell you the pleasure I had at that time. But in between, for the last few years, actually, most of us don't feel it as a pleasure. They feel a bit burdened when they go for vaginal deliveries. But we should come back to that because vaginal delivery has got its own advantages and cesarean deliveries have got its own disadvantage as well as associated complication. So I really congratulate you, Ranjana, and I am sure that the deliberations today, in which most of the things will be discussed, will be very, very fruitful for every one of us. I wish this program a great success, and thank you very much, Ranjana, for making me a part of such a prestigious program. Wish you all a very healthy, happy and bright future. Thank you very much, Ranjana, once again.
Thank you so much, ma'am, for your lovely words and your pearls of wisdom. I would like to introduce Dr. Rajendrasing Pardeshi, who's the guest of honor today in our program. And he is the president of AMOGS. He's presented a lot of papers and was VP Foxy in 2019-20 and VP AMOGS and now he's currently the president of the Maharashtra Society. So over to you, Dr. Pardeshi, to give us some pearls of your wisdom.
Good afternoon, everybody. Respected Dr. Usha Sharma ma'am, our chief guest, Dr. Ranjana Khanna, President ISOPARB, ever smiling and ever active lady from Prayagraj, Dr. Amita Tripathi, Secretary ISOPARB, and she is very active, at least 10 times. She called me, sir, are you coming? Your biodata, your even 5 minutes before also. Our Secretary, Dr. Sujata Dalve, Dr. Uma Jaiswal, Dr. Parul Khanna, conveners, Dr. Kiran Kurtakoti, our President-elect. I am feeling really honored and proud to be a part of this webinar with Padmashri, Dr. Usha Sharma, and who is the spirit of all of us, not for OP or UP, but for us also. She is a spirit. First, I wish to congratulate Dr. Ranjana Khanna, Dr. Amita Tripathi and team for organizing such a practical webinar, as Dr. Usha Sharma told, because it's really useful in day-to-day practice about the vaginal delivery, and she is promoting vaginal delivery. She is advising still to promote vaginal delivery. So this webinar is really useful because as it covers all aspects of second stage of labor, which is very important for normal delivery. Normal means vaginal delivery, and even role of Dorson's incision, which will really can definitely decrease cesarean section rate in future. As you all know, cesarean section rate is up to 39%. In Maharashtra, we received letter from government. I don't know in UP, but we received letter from government, as Dr. Usha Sharma told, she is right, to take appropriate action to reduce CS rate. I know we have reduced our maternal mortality from 556 in 1990 to 97 up to now, and even neonatal mortality also from 48 to 19. But we know still, due to the fear of Consumer Protection Act, pressure of relatives around, 5% rate has been increased, and 5% cases due to the previous pregnancy, infertility, conceived pregnancy, BOS cases, late pregnancies, this CS rate may be raised. But as our grandma told, you should try, at least give trial of labor. Without giving trial of labor, don't go for cesarean directly. We know we obstetricians facing too many problems in practice. Nobody is here without faced any problem. But still, it's our duty. But we are fear of imposing restrictions by government on cesareans. Hence, we appeal you all to follow guidelines, classify our LSS with Robson's criteria to reduce CS rate. And this webinar is, I'm telling you repeatedly, really useful in this context. I congratulate Dr. Ranjana Khanna, Dr. Amita Tripathi, and Team Prayagraj, ISOPARB, Allahabad, and Meerut Society for taking this initiative.
Thank you so much, Dr. Pardeshi. And now I would hand over the proceedings to Dr. Amita Tripathi.
Thank you, ma'am. A warm welcome from my side also to all the societies, the faculty, and the delegates. With all your support, we have reached to the final chapter of this art and science of birthing. The cervix is now fully dilated and baby is ready to deliver. And for this, we have the first session, that is the physiology of the second stage of labor. And as a speaker, we have charming Dr. Varsha Vaste ma'am. And as chairperson, we have Dr. Ranjana Khanna madam and Dr. Priyanka Garg. Dr. Ranjana Khanna, she needs no introduction. This ISOPARB Prayagraj is her vision and her baby. And she is, my association with her, as she has told, is a very long one. And I have learned a lot from her, how the things are done, how the things are conceptualized, and everything I've learned from her. And with her, we have done some very successful conferences like SEMA conference, Foxy BOH, Obstetric Dilemma, and we all invite you, all of you, for the upcoming conference that is in December. and it is known as Scientific Sangam. You all are invited for that, and ma'am is organizing chairperson for that conference. Ma'am is receiver of various awards like Foxy Achiever Award, Dhira Award, DK Tank Trophy, and Save the Girl Trophy. With this, I welcome you, ma'am. And our next chairperson is Dr. Priyanka Garg, again a very dynamic secretary of Meerut Obstetrics and Gynaecological Society. Her field of interest is minimal access gynecological surgery, and she had a vast experience in this. And she is the North Zone coordinator for the Spina Bifida Foundation, and she is executive member of Safe Motherhood Committee, and welcome and recipient of various awards like C.S. Don Gold Medal, Krishna Mukherjee Gold Medal, and Shri Prabhu Dayal Gold Medal. Welcome, Priyanka.
Thank you, Dr.
I request Dr.
Amita.
Priyanka to please kindly introduce our speaker, Dr. Varsha Baste.
Good afternoon, everybody. I've been given the opportunity actually to introduce a subject and a speaker. And both of them are marvelous, I would say, ma'am. The subject is physiology of second stage of labor. When I used to study obstetrics, I used to study the first stage, the events in first stage, and then rush over to the second stage, and then go to the third stage, the active management and how placenta should be delivered. But as Usha Sharma ma'am has said, now it is the second stage which pushes us to do cesarean sections. And hence we are talking about this stage in detail. So let us go through the physiology of second stage of labor. And the speaker for today is such a soft person, a nice friend, I would say, ever smiling, Dr. Varsha Baste ma'am. She's a practicing gynecologist and infertility specialist in Nashik since 30 years. She's the director of Basta Maternity Hospital and Pushpa Fertility Center. And apart from her friendly nature, she had the first ICSI baby in North Maharashtra and has started prenatal genetic diagnosis for the IVF pregnancies. She has been the past president of Gynae Society Nashik, chairperson for the Foxy International Academic Exchange Committee, and a winner of prestigious Dr. Anandibai Joshi Award. B for History, we have all seen that, Champions of Foxy Award, and many, many more. And as has been told earlier as well, Madam is now contesting for the post of Vice President North Zone Foxy this year. Welcome, ma'am, to this platform.
Thank you for such a nice, generous introduction, Dr. Priyanka Garg. It doesn't matter because I always make it a point to attend each of your talk because I really love your attending your talks, Dr. Priyanka. I'm really thankful to Dr. Ranjana Madam, Pranam to Dr. Usha Sharma Madam, the dignitaries, the plethora of people, my friends, Amita, then Urvashi, this beautiful Chitra, Uma, and Priyanka also there, and so many are there here, Deepika. So I'm really humbled to be here because Dr. Ranjana Madam has given us the opportunity, and pranam to Dr. Kiran and Dr. Pardeshi sir. So the labor is characterized by presence of regular uterine contraction with effacement, dilatation of cervix, the patient in labor, parturition is patient process of giving birth. Delivery is expulsion and extraction of viable fetus out of womb. So series of events take place. We all know that the expulsion of viable products of conception, fetus, placenta, membrane out of womb, and this is called in outer world labor. It may occur to 37 per completed week, that is preterm labor, expulsion, pre-viable life fetus occurs sometimes in small process, that is miniature form, that is called mini labor. So normal labor, eutosia, we all know that the precise mechanism of initiation of human labor is still obscure, but there are some hypotheses that is uterine distension, stretching effect on the myometrium by growing fetus and leukemia can explain onset of labor at least in twins or polyhydramnios. Then fetal placental contribution. Dear friends, my talk is not only of second stage physiology, but this physiology start itself from the first step. So it is a continuation of both the stages. Feto-maternal contribution. Cascade of events activate fetal hypothalamo-pituitary adrenal axis prior to onset of labor that increases the secretion of cortisol, increased release of ACTH, acts on fetal adrenals, so increased cortisol secretion. There is accelerated production of estrogen, progesterone, and prostaglandins from the placenta. This estrogen probably increases the release of oxytocin from maternal pituitary, promotes the synthesis of myometrial receptors for oxytocin and prostaglandin that increases the excitability of the myometrial cell membrane and more contractions. Progesterone, cortisol from the fetal adrenals inhibits the conversion of fetal pregnenolone to progesterone. So progesterone level therefore fall before labor, and there is alteration in estrogen and progesterone ratio. Then the next hypothesis of prostaglandin. Prostaglandins are important factors which initiate and maintain labor. The main site of synthesis are amnion, chorion, decidual cells, and myometrium. The synthesis is triggered by rise in estrogen level, glucocorticoid, mechanical stretching of in late pregnancy, increase in cytokines, infection, vaginal examination, separation or rupture of membranes. Prostaglandin secretion reaches peak during the birth of placenta, probably contributes to its expulsion, and so there is control of postpartum hemorrhage. Next hypothesis is oxytocin and myometrial oxytocin receptors. Large number of oxytocin receptors are present in fundus compared to lower segment of uterus and cervix. The receptor membrane number increases during pregnancy, reaching maximum during labor. The receptor sensitivity also increases during labor. Oxytocin stimulates synthesis and release of PGE2, E2, and F2 alpha from amnion and decidua. Vaginal examination, amniotomy rises the maternal placenta oxytocin level, that is Ferguson reflex. We all know that. Fetal plasma oxytocin level is found increased during spontaneous labor compared to that of normal mother, and that its role in human labor is not yet, but its role is not yet established. What is false label? Dull in nature, confined to lower abdomen, growing, not associated with hardening of uterus, and there are no features of true labor pains and relieved by enema sedatives. So what are the signs of pre-labor? It is like pre-monitory stage. There are cervical changes, effacement 80%, admits cervix is soft and dilatable, and appearance of false pain. Lightning, we all know the presenting part sinks into pelvis, and so there is diminishing size of fundal height, and it minimizes the pressure, and patient also feels better because of mechanical cardiorespiratory embarrassment is reduced, and that also tells us that there is no cephaloperik disproportion, and the condition prevent the head from entering inlet is not there. So also the pressure effects like frequency of micturition and constipation due to mechanical factor. So true labor pains are painful, uterine contractions are regular intervals, frequency of contraction increase gradually, intensity and duration of contraction increase progressively, show appears, voyage of 4 waters, so everything progresses. So labor pain throughout pregnancy, painless Jackson's contractions with simultaneous hardening of uterus occurs. These contractions change their character, become more powerful, intermittent, and associated with pain. Pain is more on abdomen front and radiating towards the thighs. The show, we all know there is a profuse cervical secretion, sometimes the capillary break, and there is a blood stain show. Then dilatation of internal os, which is also painful, and formation of bag of waters. Because of the dilatation of the cervical canal, the membranes are detached, and the water comes as a bag of water. And during uterine contractions, there is consequent rise of intraabdominal pressure. The bag becomes tense and convex, and that is also a certain time sign of onset of labor. So the stages of labor we all know, but we will confine only to the stages of second trimester, second stage of labor. So physiology of normal labor. During pregnancy, there is marked hypertrophy and hyperplasia of uterine muscle and enlargement of the uterus. At term, the length of the uterus measures about 35 centimeters, including cervix. The fundus is wider both transversely and anterior posteriorly than the lower segment, and uterus also assumes piriform oval shape. Uterine contractions in labor throughout pregnancy, there is irregular involuntary Braxton's contractions, which are painless. But when there is an onset of labor, they become painful. While there are wide variations in frequency, intensity, duration of contraction, they remain usually within normal limit in following patterns. There is good synchronization and contraction waves from both halves of uterus and between upper and also in between upper and lower uterine segments. There is fundal domination of contraction that diminish gradually in duration through mid-zone down to lower segment. The wave of contraction follow a regular pattern. The upper segment of uterus contracts more strongly for a longer time than the lower part. Intra-abdominal patient rises beyond 20 mm of mercury during uterine contraction, and good relaxation occurs in between contraction to bring down intra-abdominal pressure to less than 8 mm of mercury. So during contraction, the probable causes of pain is because of myometrial hypoxia during contraction, as in angina, stretching of peritoneum over the fundus, stretching of cervix during dilatation, stretching of ligaments surrounding the uterus, and compression of nerve ganglia. So intensity also is very, very important. The intensity of uterine contraction describes the degree of uterine systole. The intensity gradually increases with advancement of labor until it becomes maximum in second stage during delivery of the baby. The intrauterine pressure is raised to 40 to 50 mm during first stage, while it becomes 100 to 120 mm of mercury in second stage during contractions. In spite of diminished pain in third stage, the intrauterine pressure probably is the same like second stage, but it is diminished pain because of lack of stretching effect. What is the duration? In first duration, the contraction lasts for about 30 seconds initially, but gradually increasing duration with progress of labor. There is second stage, the contraction lasts longer than first stage. How is the frequency? In early stage of labor, the contractions come at interval of 10 to 15 minutes, and the interval gradually shortens with advancement of labor until in second stage, it becomes every 2 to 3 minutes. Retraction. This is a very important phenomenon. This is a phenomenon of uterus in labor in which the muscle fibers are permanently shortened. Unlike any other muscles of the body, the uterine muscle have the property to become shortened once for all. What is contraction? Contraction is a temporary reduction in length of fiber which attain their full length during relaxation. In contrast, retraction results in permanent shortening and fibers are shortened once for all. So the net effect of retraction in normal labor are essential property in formation of lower uterine segment, dilatation and effacement of cervix, maintain the descent of presenting part made by uterine contractions and help in ultimate expulsion of fetus, reduce the surface area of uterus favoring separation of placenta, and effective hemostasis after separation of placenta. So this is the typical phenomena of contraction and retraction of uterine muscle fiber during labor. Now, what are the events in second stage of labor? The second stage begins with complete dilatation to expulsion of fetus. It is concerned with descent and delivery of the fetus through birth canal. There are two phases. First is propulsive, from full dilatation until head touches the pelvic floor, and expulsive, since the time mother has irresistible desire to bear down and push until the baby is delivered. So with full dilatation, the membrane usually ruptures, there is escape of good amount of liquor, volume of uterine cavities thereby reduced, simultaneously contraction, retraction become more stronger. Delivery of baby is accompanied by downward thrust offered by uterine contraction, supplemented by voluntary contraction of abdominal muscles by the patient against the resistance offered by the bony and soft tissue of birth canal. There is always a tendency to push the fetus back into the uterine cavity, that is elastic recoiling of the tissue of vagina and pelvic floor. But it doesn't occur once the crowning happens. This is effectively counterbalanced by the power of retraction. Thus, with increasing contraction and retraction, the upper segment becomes more and more thicker white, corresponding thinning of lower segment. Endowed with the power of retraction, the fetus is gradually expelled from the uterus against the resistance offered by the pelvic floor. After the expulsion of the fetus, the uterine cavity is permanently reduced to size only to accommodate the afterbirth, that is placenta. Expulsive force of uterine contraction is added by voluntary contraction of abdominal, that is bearing down effort by the patient. So let me quickly take the management of second stage. It is a transition from first to second stage, which is evidenced by increasing intensity of uterine contraction, bearing down effect, nurse to push or defecate, presenting part, complete dilatation of cervix as evidence on vaginal examination. The principle is to assist in natural expulsion of fetus slowly and steadily and prevent perineal injury. Nowadays, natural in cesarean section also natural birthing is promoted. Just like that, we have to be very patient for such patients. The patient should be in bed or she can be moving constant supervision is mandatory. FHS is vaginal delivery, vaginal examination must to rule out accidental cord prolapse and also to assess the descent of the head. How will you prepare? We all know she can be squatting, lateral partial sitting, 15% left lateral tilt to avoid aortocover compression and facilitate pushing effect. Nurse scrubs up, toileting of vagina with Dettol and other solution is mandatory. Sterile sheets, conduction of delivery. Delivery of the, it is in 3 phases: delivery of the head, delivery of the shoulder, and delivery of the trunk. So delivery of the head is followed by maintaining the flexion of the, always you have to see the flexion of the head is to be maintained to prevent its early extension and regulate its slow escape out of vulval outlet. Patient is encouraged for bearing down effort during uterine contraction. This facilitates descent of the head. When the scalp is visible about 5 centimeter diameter, the flexion of the head is maintained during contraction. And this is achieved by pushing the occiput downwards by using thumb and index finger of the left hand while pressing the perineum with the right palm by steadying the vulval pad. And if the patient passes stool, it should be clean. So this is the Ridgen maneuver. We all are familiar with it. Process is repeated during subsequent contractions until the subocciput is placed under the symphysis pubis. At this stage, maximum diameter of the head, bipyramidal diameter, stretches the vulval outlet without any recession of head even after contraction is over, that is crowning of the head. The purpose of increasing the flexion of the head is to ensure that small occipitofrontal diameter, 10 centimeter, descend the vulval outlet instead of large occipitofrontal diameter, that is 11.5 centimeter. So delivery of the head. When the perineum is fully stretched and threatens a tear, especially in primary gravida, episiotomy is given as per the patient's condition. 10 ml of prior infiltration with 10 ml of 1% lignocaine. Bulging thinned out perineum is better criteria than visibility of only 4 or 5 centimeter of skull to decide the timing of performing episiotomy. Slow delivery of the head in between the contraction is to be regulated. The forehead, nose, mouth, and chin are thus bond successively over the stretched perineum by extension, and episiotomy is given. So care following the after coming the head. Immediately following delivery of the head, mucus, blood carrying should be cleared to free out the air passage. Eyelids wiped and neck is palpated to exclude the presence of any loop of cord. So the care of the head. Prevention of perineal laceration. More attention should be paid not to the perineum, but to the controlled delivery of head to avoid the perineal injuries. Delivery by extension is to be avoided. Spontaneous forcible delivery of the head is to be avoided. To deliver the head in between contractions, to perform timely episiotomy when indicated, to take care during delivery of shoulder, as wide bisacromial diameter 12 centimeter emerges out of introitus. That all will reduce the perineal tears. The delivery of the shoulder should not be hasty. It should be done slowly. Wait for the uterine contraction to come, movement of restitution and external rotation of the head to occur. During the next contraction, the anterior shoulder is to be pushed behind the symphysis. If there is delay, the head is grabbed by both hands and gently drawn posteriorly until the anterior shoulder is released from the upper pubis. By drawing the head in upward direction, the posterior shoulder is delivered out of the perineum. And traction of the shoulder should be gentle to avoid excessive stretching of neck, causing injury to brachial plexus, hematoma of neck, and fracture of the clavicle. So this is the way we do deliver the shoulder. Now, delivery of the trunk, we have to put 4 fingers in each hand to be inserted under the axilla, and the trunk is delivered slowly by lateral flexion. So, immediate care of the, what is the immediate care of the newborn? Soon after delivery of the baby, it should be placed on tray covered with clean linen, facilitates the drainage of mucus. Tray should be placed between the leg of mother. It should be lower level of uterus to facilitate gravitation of blood from placenta to baby. Air passage to be clean. Apgar score should be recorded. How to clamp and when to clamp. Clamp is, the cord clamp is by 2 Kocher's forceps. One is placed 5 centimeter from the uterus and cut in between. The cord ligature is applied 2.5 centimeter away from the navel. Presence of any abnormality to be noted. And the cut end, it you need not cover, but it should be, we generally put some iodine or to sterilize it. Delay in clamping for 2 to 3 minutes till cessation of cord pulsation facilitates transfer of 80 to 100 ml of blood from compressed placenta to baby when it is placed below the level of uterus. This is beneficial only for the mature baby. But if the baby is deleterious or preterm or low birth weight baby, don't do it for hypervolemia or hyperbilirubinemia. But early clamping should also be facilitated in case of RH incompatibility to prevent antibody transfer from the mother to the baby. And the baby should be given for sucking the mother immediately. So thank you. Thank you for your patient hearing. I'm going for the post of Foxy Vice President where Red zone, मेरा चेहरा देखना और सिक्का मारना. Thank you.
Varsha, that was a
Okay.
very complete presentation. I was literally standing in the labor room all the time when you were giving this talk, you know. It almost felt as if we are going to actually deliver. So you have brought the points out very well, and some salient points have come out very well. One thing we must always remember that for labor to progress normally and correctly, there should be a correct relationship between the 3 P's: the power, the passenger, and the passage. That should be in the correct relationship, and then everything becomes smooth. And as you have rightfully said, there are 2 stages. Basically, in the second stage of labor, there are 2 phases. One is the latent or the propulsive phase, where it comes down from the full dilatation, the head comes into the pelvis, to the pelvic floor. And then is the active or the expulsive phase, when the head is actually expulsed out. So these things have been brought out very well, and we should be very, very clinically efficient in seeing the any CPD. We have to be very careful about seeing that, because otherwise we'll land in hot soup if the patient goes into obstructed labor. And we must be very careful that until and unless the cervix is fully dilated and the patient has entered the second phase, we must not tell her to bear down. Otherwise, she'll end up in prolapse later on. So we have to be very careful about these small things. But you have brought out the whole physiology very well. And thank you so much. I appreciated the talk.
So thank you, Varsha ma'am. Thank you, Chairperson Ranjana ma'am and Dr. Priyanka for excellent talk and excellent inputs. And so we have completed the physiology. We have learned all the things. Now coming the next very important thing, that is delay in second stage of labor. And speaker is lovely Dr. Komal Chauhan. And to chair the session, we have with us Dr. Sujata Dalvi and Dr. Chitra Pandey. Dr. Sujata Dalvi is Secretary of AMOGS. She is librarian of Mumbai Obstetrics and Gynaecological Society, and she's joint associate editor of Jogi and president of Mumbai Menopausal Society. Welcome, Sujata ma'am. Sujata ma'am is here or not? Deepika, can you tell us? I can't see her.
Ma'am, I can't see.
Okay. And next is Dr. Chitra Pandey. Next is Dr. Chitra Pandey, very dear friend. She is, right now, she is chairperson of Women's Wing of IMA Prayagraj. She is Vice President of ISOPARB Prayagraj and Vice President in Allahabad Obstetrics and Gynaecological Society. She has been with us in all our journey through the conferences, and she is, we can say she's friend, and we have been all together in everything. Welcome, Dr. Chitra, and I will request you to kindly introduce the speaker, and we'll see that Dr. Sujata has joined in between or not.
Thank you. Thank you so much, Amita. Thank you so much for the kind words. Good evening, everyone. So now, after understanding the physiology of second stage of labor, let's move to another very important topic, which is very important as most of us, we practice obstetrics day in and day out, and delay in the second stage of labor is very unpredictable, as the proper antenatal assessment and the smooth first stage of labor progress, it is not a very reliable predictor that everything will go well in second stage as well. It has its unique challenges, and besides the wisdom, knowledge, teamwork, the most important thing which is required is timely balance between the timely intervention and masterly inactivity, when not to act is equally important when we face the challenges. And to deliver this talk, we have dynamic and brilliant speaker, Dr. Komal Jawan. Dr. Komal is chairperson of FOXY Medical Disorder in Pregnancy Committee from 2019 to 2022. She is FOXY President Western Coordinator 2022 to 2023. At present, she is Senior Consultant TNP Teacher and Unit Chief at VN Desai Hospital, Mumbai. And she is Medical Director of Jawan Maternity and Nursing Home. And she has so many important things and awards to her credit. So now I request Dr. Komal, I invite you to deliver your talk. We are very keen to hear you.
Yes, thank you. Thank you so much, Dr. Chitra Pandey. And thank you, Ranjana Madam, for this opportunity. Usha Sharma ji, thank you for being there. I'll start my presentation. And
Chitra, you forgot to add one thing, that she is also contesting for the post of Vice President FOXY. And needs our blessings and support.
Yes, of course, I need Madam your blessings and support. And it is, the elections are very near now. So, so that is what we think about election all the time. But now we are in the labor ward. So now I'm in the labor ward thinking only about how we can actually prevent this delay in second stage. So I thank you for the introduction, and my topic today is delay in second stage of labor. And I remember, I think Ranjana Madam is doing this lovely series, you know, this art and science of birthing. And I think this is her final push, is like it's like an icing on the cake. You know, she started the early series where I was there, part of Piley, the breech delivery. I think I have been there, part of your webinars earlier. And this scientific Sangam is too good. So thank you, Ranjana Madam. Thank you, Usha Sharma Madam, Pardeshi Sir, Sujata Madam, Chitra Pandey, and Amita Tripathi, Uma Jaiswal, and Parul. I think she's very dynamic and a sweet person. So thank you for making me part of this program. And I'm going to talk on delay. So the previous talk, we have heard about everything about second stage. So I'll focus mainly on delay. But we know that labor is the expulsion of the viable products of conception. And when it comes out into the outer world, and that is what is labor. And labor is also the joyous moment for the mother. And when patient delivers, even we become happy. You know, that patient, we had 4 patients in labor, or 3 delivered, we become very happy. So everybody becomes happy when everything delivers and it goes good. But at times there can be delay. And the delay, how do we know that it's a delay? Because there has to be a normal progression. So what is a normal progression? In a nulliparous, around 50 minutes, that is the average duration, multi around half an hour, and then came the maximum duration. So this was a minimum duration, then maximum duration till 2 hours, and in multiparous till 1 hour. And then WHO said around 3 hours is also okay in nulliparous and 2 hours in multiparous. So we know that this is the terminologies. But do we actually go by these terminologies? Do we need to know what is actual delay, how it is going to occur? I think we know when the second stage starts. So second stage actually starts when you know that the patient is actually pushing to bear down. If membranes are not ruptured, it will rupture. You will not feel the cervix. It is fully dilated, completely taken up. Urge to defecate is there. And here you just maintain the cleanliness, put drapes, you see the crowning, you give an episiotomy and you deliver. So the Ranjana Madam spoke about these 2 phases, and they are so important because we need to know that these 2 phases are so important. Why? Because propulsive stage starts from the full dilatation till the head touches the pelvic floor. And after that, after the head touches, that impulse make a sudden bearing down. The mother will have that bearing down, pushing down, and she will try pushing it. And that is the expulsive force which the mother does it herself. So it is very important that this propulsive is caused by the contraction, but expulsive is the mother's urge to defecate and bear down and deliver. So when we talk about this, we also know that there is a simultaneous uterine contraction as well as retraction. Uterus is going to be elongated and the contractions are going to get intense. And the elongation is partly due to contractions of the circular muscle fibers, and uterus is kept at the fetal axis straight. So this downward thrust is very, very important. I think this was spoken, so I will not go into detail, and followed by an elastic recoil. So both are very important, but sometimes you see, what you see, your head is coming down with a contraction, it goes back. So you're confused. The head is receding with every contraction. So that we will not call as station coming down to at the perineum, or a station at +2 station. So sometimes there is an elastic recoil also because of the vagina and the pelvic floor. So we need to know. So when we know things are going good, when we have a patient who has had a previous vaginal birth, descent is occurring, everything normal, there are no other comorbid factors, we have assumed that the pelvis is adequate, and we have even assessed the pelvis in labor. Height, obesity is not there, fetus is occiput anterior, there is no caput molding. These are the favorable parameters. Maternal condition is good, there is no infection, we need not worry. The fetal weight is also very good. It is not very on the heavier side, not SGA baby. And maternal exhaustion is not there. Patient is pushing down very well, reassuring fetal heart sounds, and everything is all good, and patient is nicely proceeding in labor. This is a reassuring picture, and we see this at times, but at times it will not be that reassuring. We will have a delay. And then this was the recommendations which came, because what happens, this delay, what we are talking as a second stage delay, is the time when we should intervene, and that decides our operative rates also. So the ACOG and Society of Fetal Medicine, they came up with these strong recommendations, and they said that at least 2 hours of pushing in multiparous and 3 hours of pushing in nulliparous. This was a grade B recommendation. And in these recommendations, you call it delay, and then with a strong recommendation, again with 1B, they said that operative vaginal delivery should be given, and it should be tried before we go for cesarean section. Even a malposition can be treated by manual rotation of the fetal occiput. We will talk about all these. So these recommendations have come. So we really need to know that how to go about treating this delay, how to upgrade our skill. And this was again a trial. This was by a 78 nulliparous, were primary women, and they compared the old approach, that is waiting, that is 2 hours without epidural to 3 hours with epidural, to a new approach of waiting 3 hours without epidural and 4 hours with epidural. And they thought about how the delivery process is going to go. And there was a decrease in the cesarean section. Definitely, they had a very good outcome, but the trial had a very less number of women. And we really require larger study, larger cohort studies, designed studies to know whether this is really going to act. So this, we require a large observational study. It is ongoing and it is taking time, but we really need our Indian studies also, because Indian women are different. We cannot go by the studies done by the other part of the country, because we want our approach, our women's education, their willingness to wait. Today I have an IUFD patient who has been referred, and she is so hyper, she just wants to get cesarean done. So the threshold of patient also is so important. They just give it at some time. They say, no, I don't want to go this long, and please deliver me. So diagnosing of delay is very important. And as the definition said, with epidural, maximum till 4 hours you can mate. Without epidural, definitely in a nulliparous, it should be little early we should diagnose, because epidural, I need to add 1, and then multiparous with epidural 2 hours, and without epidural 3 hours of pushing. So that is how you diagnose delay. But you don't have to just keep diagnosing delay, because I think when Ranjana madam also pointed out that we tell our patients not to push too much, because patient starts pushing. And if patient has pushed for around 60 minutes, she's completely exhausted. We cannot ask her to push more. The maternal exhaustion will come. So when you know that patient has been actively pushing, you cannot just tell her to keep pushing. You need to add on to something. If you feel the activity is good, fine. There can be again reassess, put your hand. find out whether it is a hypocontractility again, or it is uterus is going into uterine inertia. And here you can augment with oxytocin if not done. And if you feel everything looks okay and still she's bearing, then you can consider for the operative delivery. So this is just an algorithm of a primary gravida patient with no epidural. And how do we go about? We really need to assess everything, including if the epidural was given, the hydration, the output, the descent, the contraction, the dilatation, position, everything we need to reassess again, because now the patient has got fully dilated. It is not the way we started, that she was back was anterior and occiput was anterior. We know all the findings, but we need to see at the perineum when she's fully dilated, where is the station, what is the position, fetal position, is there a caput molding? You need to know that. You need to empty her bladder. You need to maintain the hydration. If the membranes are not ruptured, amniotomy needs to be done. Consider the manual rotation also, reassess, and then reassess again after an hour, after doing all this, after starting oxytocin. And if it is not working, then you can think about an operative delivery. If that's not working, you need to go further. So decision making is really important, and the right decision making for the patient is good, because we need to analyze the fetal as well as the maternal outcome. So if there is an epidural given, definitely you need to go ahead with the same parameters. You need to assess the same way. It is not that, but at 2 hours, you will need to act. You will need to act. At first hour, you will do the examination, you will reassess, start and intervene, and then wait for maximum 2 hours. And if there is a multiparous with or without epidural, you again need to reassess after 1 hour of full dilatation. And if you don't see any active change, reassess and then aggravate your care, what you can give to this patient. Give her the justice so that we deliver this patient vaginally. So this is how we go about. And then coming to the manual rotation of the occiput, Dr. Piley also does it very well. And this is a very simple technique. We need to just master and know it. You know, the occiput is transferred. Head is not very deeply engaged or impacted. Here, you can just put your 4 fingers below, and hold, and you have to, in a pronated hand, you hold the head. The thumb is anterior, and how it is getting rotated from this angle. So from transverse to anterior, the green arrow is showing that you need to rotate. So it is at the transverse, you rotate and get it to the occipital anterior. So you can rotate it, and then after rotation, you can apply an outlet forceps or a vacuum and deliver this patient. So this is how we can do. If the patient is occipital posterior and you want to rotate, you can use alternatively your left hand, and that will give a better positioning and rotation maneuvering when you use it for occipital posterior. So these things are coming back into picture. It is not that these are absolute, but really when we know the pricing rate of cesarean are there, we need to restore to this manual rotation technique. Sir Ian Donald said, give me a pair of outlet forceps and a Kiran forceps, and I will practice obstetrics in any part of the world. And so we need to revive this vacuum and forceps, because this is a time when we know that patient is completely exhausted, or that her bearing down efforts are not very good, and there is a delay definitely happened in our second stage. We need either of this, and when to use what will decide is the indications and the contraindications. So we know patient is not progressing fully, there is a distress, and there is not completely rotated. We can use a vacuum. So vacuum is something which doesn't require a completely rotated occipital anterior, and you can use vacuum for rotational as well as giving a good pull with oxytocin. Then this is a simple video. So this is how
the baby is not coming out despite the mother's efforts.
It is hit, so you can use a vacuum. So catheterization is very important before you apply a vacuum, and empty the bladder. Very, very important. This is the first step before every instrument is
suction device is
and then check your suction device. This is a kiwi cup, a small handy cup, which is used. You can put it in the center. You need to be very careful that no cervical tissue has come inside.
Wait for the contraction
and
apply downward and outward traction to deliver the head.
And this is how
apply traction in a line perpendicular to the plane of the cup rim. This can be repeated with contractions 2 to 3 times as needed. When the head is delivered, release the vacuum, take off the suction device.
Okay. So this is how, and there are newer techniques also. I'm not going into what conventionally the Kiwi cup is a handy. Yeah, I'll just show you later in the video. This is a Odone device. And then coming to the forceps. So forceps, you will definitely put when you know patient has failure to progress. We require a full dilatation here. We require a rotated occiput anterior and a good episiotomy to begin with. And the forceps should be an outlet forceps. We don't really apply a high forceps. That is not recommended. So choose your patient, see if the blades are going properly. Always lock the blades and then try to pull. There is no single blade or unlocked blade application. And then comes the second stage where you have tried everything and you really need to take this patient for cesarean section. So when you take this patient for cesarean section, that is also not very simple after second stage because the head is deeply engaged and you require an assistant to disengage the vaginal end. You require a help, and with the assistant pushing the head up, maintaining the flexion. The pushing should not be against your delivery angle. You know, you need to maintain the flexion. At times the head gets extended and it becomes very difficult. Then pushing is one technique. If it is not helping and the uterus is very gripping the baby, you may require a T-shaped incision or an extension of the incision. Then comes the Patwardhan maneuver. I think we Indians are very trained at it. We do it very well. And we deliver the baby by modified Patwardhan's maneuver. That is the arms, shoulders, then the fetal trunk, then both the legs, and then baby is turned caudally and head is just scooped out. It just comes out. So then comes the reverse breech extraction by Arun Maran. He has said that this is another technique which you can do. And rather than delivering the arms and everything, you first go to the breech, pull the legs, and deliver it as a reverse breech. So this is also one technique which you need to know. The debate lies between pull and push. Which is better? Pulling is better or pushing is better? And these debates are already debated because the fetal injury rate they are compared. But believe me, all studies shows that the injury rates are more or less the same, whether you push or pull.
But breech extraction is very good. And it never causes any problem. It's the best.
Best. And then there in UK, there is fetal disimpacting system or a fetal pillow. You know, they are inserted below the fetal head vaginally, like at the time of bladder catheterization. And just before the uterine incision, the assistant inflates the balloon with 180 cc's of normal saline. And this basal plate flattens, they elevate the fetal head goes up by almost 3 to 4 centimeters, and the head goes up, and it is very easy to deliver. So such things are not available at our place, but because we are trained at Patwardhan, they are not available. But in UK, they are available, and they are using this impacting system. Then what about the risk? We know, coming to the complications, definitely the deeply engaged head and everything, because of the thinning of the lower uterine segment, we have extensions. We have extension to the surrounding areas. We have traumatic PPH. All these, even the technique, how we are going to maneuver, it is definitely going to extend the incision. Then PPH, maternal infections can be more. The operative time may be more. And neonatal outcome, because we have tried pulling from down, we have tried then opening and delivering. So this baby can be prone to an NICU admission or sepsis. So this outcome worsens. So there are some managements which have been discussed and they are not found to be very effective. It's like just turning the patient. They have said that you can just turning down the epidural or changing the maternal position. So turning down epidural is, you know, the patient is in epidural, you try to bring down because the patient is not able to push because of the epidural. And this was a meta-analysis including 5 trials in which this epidural will randomly assigned to anesthetists, and this was discontinued late in labor. And then they did not clearly reduce the instrument delivery. So actually nothing happened, but they said that when your patient is on epidural, you stop it in between and you check whether this patient will deliver. So this did not show a dramatic improvement. Then changing the maternal position, that is, after you know that there is an arrest, then you make the patient upright or tell the patient to go on or all hands for treatment of prolonged stage, second stage. Ideally, they should be made comfortable to choose the position at the beginning. So when the arrest has already occurred, the changing has not helped that much. So how do we prevent? So the key lies in prevention. So I think delayed pushing. This is very important. A meta-analysis of almost 12 trials over 5,400 patients. They said that in the second stage, if you encourage the patient not to prematurely push down, then the exhaustion is very, very good. And delayed pushing is something which we can prevent the delay to happen. Then maternal position technique, which we actually spoke now, that this maternal position, and we tell them to take the position of their choice right from the beginning. When the patient initiates and starts having good contraction, she chooses the position, maybe an upright or on all fours or a dorsal, and definitely the second stage of labor will be shortened. And this is how the video is there. This is a patient who is in labor, and we really need to encourage this patient to turn around, to listen to her and to see how she's feeling and take the position of her choice. All four position is very good for even a breech delivery. They say that even the breech trial, we can deliver the breech patients very, very smoothly, and the term breech trial says that. So also pelvic floor muscle exercise. This also has come as a preventive, that we need to train the pelvic floor muscles of some patients. You know, the healthy nulliparous patient, when randomly assigned antepartum pelvic floor muscle training program, it was given between 20 to 36 weeks. And they found this pelvic floor training may sometimes prevent the prolonged second stage. And this is a large trial. So I thought to complete, I can just quote this. And then continuous labor support. You know, in a meta-analysis of randomized trial, continuous one-to-one intrapartum support by trained and untrained individual resulted in small but statistically significant improvement in pregnancy outcome. So this continuous labor support, like somebody being with the patient, maybe a trained or an untrained individual also, like a birth companion. I think putting a birth companion with the patient definitely gives a good outcome. So these are just the techniques which we can do to prevent this delay in second stage. And training of obstetrician, very important. I'll just end with this slide. So this is how we train. Actually, this was in an RCOG conference with the AICC RCOG, where Tim had come, and he was training us on the Odon device, because they are very fancy and they tell us all these techniques. So he gave us a nice demonstration, the video which we couldn't play. This is a nice Odon device which goes on the fetal head. It just traps the fetal head and you just pull it. It is less traumatic to do fetal head. There is no suction applied directly on the head. So this is the Odon device training with Dr. Rishikesh Pai and even Paili sir being there. And then later on, we meet again after 2 months in the AICOG Kolkata, and where we are having a workshop, and we teach him how to do a Patwardhan maneuver, because they don't know Patwardhan maneuver. They always believe in, you know, pulling or the reverse breech extraction or the other technique. So we are teaching him Patwardhan. So it is training which we give to each other all across the globe. It is how India has given the Patwardhan maneuver to the rest of the world. So I'll end with a quote: "Be the change that you wish to see the world." This is by Mahatma Gandhi. And the change begins in your outlook, how you manage the patient. You don't cause delay. And if there is a delay, you try to introspect why there was a delay and try to prevent in the next patient which you manage. And at the end, just a humble appeal. E-voting is going to start from 1st of August to 10th of August. And I am your candidate for the post of Vice President from the West Zone. And I have been working for medical disorders in pregnancy committee, and I want to work again in FOXY, and make me your choice. Thank you so much for your patient hearing.
Very nice talk, actually, Dr. Komal. Very nice talk. But then, you know, it depends on which maneuver you have mastered.
Yes.
Like I have mastered the technique of reverse breech. Whether
Oh,
it's
wow.
obstructed, whether it is free head, whether it is obstructed, it seems very convenient to me. Just put my hand inside, catch the breech and take out the baby. So I'm very comfortable with that maneuver. So
Very
I
nice.
think it is like you are proficient in Patwardhan and you'll prefer that. But somehow I'm always scared in Patwardhan that you can end up, damaging the brachial plexus or something. And this way seems very easy for me to just catch hold of the breech and pull out the baby.
Baby, I think you're UK, you're RCOG person. Because they are very scared. They were really scared to do the Patwardhan. But I think it's a simple, very simple. I do it routinely.
Yeah,
My juniors are doing it. They're all trained.
Yeah.
So I don't have to
Exactly.
go and
So it depends on how you proceed with it. We were so proficient in putting forceps delivery. Remember, Kirti, in our time, there's so much of forceps applications, but just see the rotation and put. But nowadays, the juniors are not being taught all that.
They don't know. They don't know. That is in our times, we used to apply even prophylactic forceps.
Yeah.
For anemia, for
Even now-
PIH. Working with Dr. P.K. Shah, his rule was to apply forceps. So at the time the patient used to deliver, we are running with forceps.
But now, ma'am, we are using ventus and forceps in cesarean sections because we are now more into free-floating heads rather than these deeply impacted heads. And I am routinely using ventus in my practice, and it is a good choice. And many of the doctors here, they say they use routinely forceps for very, very free-floating heads. So it is just
I still like to take it out by reverse breech.
I like vacuum.
Free-floating head by reverse breech.
Free-floating head, my choice is vacuum. Vacuum works very well.
Forceps is also very good. Vectis forceps, very good. Single blade.
Even
It's
Vectis
very nice.
forceps and ventus, both of them are very good.
Ventus is for free-floating head.
It is saying that it depends on which technique you have mastered over the years.
मुझे ऐसा लगता है मैम उन्हें पहले cesarean में लगाना सिखा दो ना, PGs will become more confident in vaginals then. They'll be used
The
to
PG should
No,
be
see, that is
actually
different.
trained for instrumental deliveries.
Yes.
That will reduce the C-section.
Trained for the
rate.
same indication. So cesarean forceps will be completely different from the outlet forceps what we apply.
Yeah.
I have seen people don't have confidence of forceps at all because they don't know how to lock it.
We
Don't
didn't have
understand the
mid
pelvic
cavity
curve.
in our hospital. Where in GSVM, we did not have mid cavity, only Wrigley's outlet forceps.
Yes.
So we were very adept with that.
No, but now people are not, even for the outlet, madam.
Yeah.
Outlet also they don't know. They are really lacking instrumental because they know the safest way out. That is the reason, they anticipate, they don't want a deeply engaged head. We don't want a complication. Even if you take for section, yes, we have waited, and then suppose
Ranjana,
the bladder goes or there is extension.
I would like to share with you Dr. B.N. Purandare, with whom I worked. I was a student. He used to tell me, because I had this Kellan forceps. My father was also a doctor. He used to apply those, and he was ENT surgeon, but he was like all doctor, all faculty doctor. So Dr. B.N. Purandare told me, "Oh, craniotomy, everything you keep it. Kellan forceps also you should know because you are going in the small city. वो village में जा रही है नासिक में, तुमको सब आना चाहिए." So I was trained more because there were no anesthetists where I started working in Pimpalgaon as well. So more I used to do for forceps delivery. So that is what we all we used as instrumental delivery to avoid C-section.
Yeah, madam, actually, see, the point is now why we are scared because of a lot of medical legal issues also.
Yeah,
because if we apply a forceps, which we do, and if there is by chance any maternal problem or a bad adverse fetal outcome, nobody wants to go through the maternal thing because they feel doctor ne chimta lagaya, some problem happened. They are just going to condemn. So everybody is actually scared because of the patient awareness. We really don't want any medical legal problem for any of our patients. So that is the reason we are more, that even the terminology is like 4 hours.
I think let's go on to the next.
Yes, we can't wait for 4 hours because we know we will be stressed. So I think that is also the...
Thank you, Komal ma'am, for beautifully covering the topic. Now we move on to our third session, which is role of Derson's incision in modern obstetrics. And our speaker for the day is Dr. Sneha Bhuyar ma'am. I would now like to invite our chairpersons for the session. Our first chairperson is Dr. Kiran Kudkoti from Pune. Sir is Vice President of AMOGS, Director of Sashwat Multi-Speciality Hospital in Pune and Ond, ex-chairperson of MTP Committee of FOXI, and he has been recipient of various awards. Dr. Suili Rudra Sinha Prize for Best Paper in Endoscopy, and Dr. C.S. Dawn Prize for Best Paper at AICOG Chennai. Sir has various publications to his name. I welcome you, sir. Our second chairperson is Dr. Archana Goyal. Ma'am is currently Secretary ISOPARB Meerut Chapter. She is Director Siddhivinayak Medical Center Meerut, Executive Member of FOXI Meerut, and Executive Member of Women's Doctor Wing of Meerut. Her special interests are infertility and laparoscopic surgeries. Welcome, ma'am. I now request Dr. Archana Goyal to introduce our speaker, Dr. Sneha Bhuyar, ma'am, and Dr. Kiran to give his expert comments.
Good evening, all. I initiate with a word of thanks to the organizing committee for giving this opportunity to me for sharing such a valuable platform. After two very informative talks on labor, this is a time for third talk on role of Ducherson's incision in modern obstetrics. So when a patient comes in labor with prolapsed cervix with untrapped head, we have to take decision at the earliest to prevent perinatal mortality and morbidity and to prevent unnecessary cesarean sections. So to present this topic, we have a very learned speaker with us, Dr. Sneha Bhuyar, ma'am. So I take pride in introducing Madam. She had embarked her career 30 years ago and has a rich experience of over 300 talks, orations, and bags over 25 national publications. She had been the FOXI Breast Committee chairperson from 2019 to 21 and GCM ICOG in 21 to 22. If I talk about her achievements, she has been awarded with International MS Signature Award for Phenomenal Leadership 2020 and Asia GCC Award in 2021. In a row, she is the recipient of many awards. There is a long list. She has also been decorated with Dr. Anand Joshi State Award by Government of Maharashtra, Lokmat Healthcare Excellence Award in 2020. We're highly elated to have you, ma'am, amongst us today. And madam is also contesting for the post of Best Zone Vice President. Welcome, ma'am. Over to you.
Thank you so much for the kind and generous introduction. Dr. Archana, a very good afternoon to all of you. I'm sure you have, by now you know that I have a rich experience of at least 30 years, 3 decades of my obstetric career. More than 20,000 deliveries I have done individually, independently in a nursing home. And of course, I have been trained from the Premium Institute of BJ Medical College, Pune, as my entire medical education, practicing in the small city district place of Yavatmal. Dr. Ranjana Khanna, a very dear friend, Gynae Council member with me, and we all of us share our views every time. I was really surprised. I have been talking extensively on the difficult vaginal deliveries. I have been moderating panel discussions on the labor emergencies and difficult deliveries, but I was surprised to receive these topics. But without any further question, I just accepted. And so this is the disclaimer: no conflicts of interest whatsoever, presenting as assigned the topic, and not much of personal experience, except witness only once, that is 33 years back, when my senior has done this for a dead fetus, and one more for a prolapse case where the head was outside the introitus but inside the cervix, that I have done personally. So friends, Ducherson's incision, all of you know that it is a cervical incision. Though a forgotten art, it has got several roles and debates in the modern obstetrics as well. Just going back to the history, Alfred Ducherson, he was a German obstetrician and gynecologist. He was the, then he was the advocate of the screening of the antenatal women, or antenatal care and screening of all the pregnant women. and of course the advocate of the institutional births for all pregnant women. So 1890s, that was a period when he published a paper describing cervical incision and even the extended perineovaginal incision for the dilation methods of the soft birth canal. And in obstetrics textbook, this is called as Duherson cervical incision or hysterostomatotomy, that is opening of the mouth of uterus, hystros. So in 20th century, this method has now become almost an archaic obstetric method. Whatever indications that time it was used, I'm going to present you a few statistics also, but they are quite old. Urgent indications like immediate delivery because of fetal distress during second stage of labor, cord prolapse, especially when the cervix is 6 to 8 centimeter dilated. She has very good roomy pelvis. The labor is progressing well. I'm sorry, somebody needs to mute. So the labor is progressing well. The pelvis is adequate, but it's just the cervical ring that is an obstacle for this baby, and maybe a little large size baby where further stretching of the cervix is not possible. Incomplete cervical dilatation during forceps application and vacuum delivery. So here again, pelvis is adequate, contractions are good, the presentation is vertex, everything is fine. Sometimes back they have said that previous scar, when it gets stretched during second stage of labor, that is a time where it may just rupture. So try to minimize this stretch by giving a cervical incision in cases of VBAC. Cervical spasm after internal version in cases of preterm delivery, and of course the entrapment of the aftercoming head in cases of breech presentation. Entrapment of the head in cases of uterovaginal prolapse, as Dr. Archana was talking about, especially when you have everything fine and it is just the head which is stuck up because of this cervical ring. So how do you do this incision? This is just a diagram showing you the exact position. But here it is described that you take with all aseptic precautions, you catheterize the bladder and you mark your place of incision at 2 o'clock position and 10 o'clock position. Why not laterally? Because laterally you have the descending cervical vessels, and if in case the incision extends because of the traction, maybe because of the size of the baby, then it may just hit the descending cervical vessels and it may just cut through and may develop the broad ligament hematoma. The main difficulties in performing cervical incisions in head entrapment in a breech delivery are achieving adequate analgesia and exposure. And there is a significant risk of hemorrhage. The cervical incision may even extend upwards even to the lower uterine segment and maybe even to the broad ligament. So may cause broad ligament hematoma. So here is the exact procedure, how it is done with the help of the Mayo scissor. This left, this is the black arrow, which is showing you the 10 o'clock position, and this is the white arrow which is showing you the 2 o'clock position. So that is how you're supposed to make an incision, and that has to be a very controlled incision. What are the complications of this incision and what are the contraindications? Naturally, the placenta previa, the placenta which is lying low, in fact, low-lying placenta, that is the placenta previa, is an absolute contraindications. Of course, all of you know that when you have pelvic inadequacy, there's absolutely no point because she's not going to deliver. So that is also an absolute contraindication. The complications which are described and which are experienced, postpartum hemorrhage, there is an increased chance as if you are facing the traumatic PPH. Healing of the cervix, yes, definitely there can be poor chances for healing of the cervix in few cases, increased chances for infections, and of course, increased chances of fetal as well as maternal morbidity. This is the statistics I was talking about. The role of Duherson's incision in prolonged labor. This is the data from the Chicago Maternity Center. But all of you can see the data is from 1932 to 52 only. And all of us definitely agree to this, that in modern era, nobody is using this method of cervical incision and delivering the patient vaginally. So they have lots of data saying that 55,577 patients they have delivered using 149 cervical incisions, and this is how the outcome was quite good. Even the complications were not many. So this is just for your reference. These are the certain references which I could find here. In fact, the Cochrane database also doesn't show many cases which have been delivered, but here is this is a case report on 3 cases, and this is by Dr. B.K. Goswami, A.R. Bhattacharya, and Dr. G.S. Mandal, and it says that these cases of cervical dystocia treated with Johansson's incisions they have reported, and these cases show that even in the present day obstetrics, there is a place of Johansson's incision in properly selected cases. So as all of us are discussing, if at all you are well versed with the procedure, if you are comfortable with the procedure, of course, practice makes the man perfect. So unless we use it, we're not going to be expert in this incision. So that is what the conclusion is. One more report I can share with you, that this is also by Dr. Ankita Chakrabarti and Dr. Bandana Sham Gohen. And this is the vaginal delivery by Johansson's in a case of uterine prolapse. So the conclusion here was the uterine prolapse in pregnancy, though rare, but it's the incidence in the, naturally in Indian women, the incidence is higher because of the multiparity and the closely spaced deliveries without any period for recovery. And of course, the subsequent larger babies and, the home deliveries and large, maybe the old heel tears. So all these may be the reasons which are contributory. And that's a very reason we may have prolapse in Indian women, the incidence is higher. The management of uterine prolapse during labor is individualized depending on the severity of the prolapse, gestational age, parity, and the patient's preference. The Johansson's incision is very convenient, simple procedure by which the delivery can be conducted vaginally and thus reduces the need for cesarean section, as illustrated in this case. This is again the reference from PubMed. Now, the National Library of Medicine, here, salvage from cervical dystocia in 3rd degree uterovaginal prolapse. So here they have again concluded that uterovaginal prolapse in pregnancy is rare. Opinion is divided on the delivery options, but most of them agree that cesarean delivery and conservative follow postpartum is the preferred method. Prevention of pelvic organ prolapse, though antenatal supervised delivery, physiotherapy, and fertility regulation remains the key to the favorable outcome. So this is a case by Verma ML, which is actually the same case they have presented as a report. Salvage from cervical dystocia, 28-year-old woman, second gravida with a full-term pregnancy, presented in active phase of labor with 3rd degree uterovaginal prolapse. You can see the head is outside the introitus, but inside the cervix. And here you don't have option for cesarean sections, but the only treatment, I would say, but just to give an incision on the cervix. And so they had given an incision and the baby and mother fine. So that is what the case report. Here, one more. This was an unregistered, uninvestigated patient, full-term pregnancy. She came in active labor with 3rd degree uterovaginal prolapse, and the baby's head was outside the introitus but partially dilated cervix, and it was catching the head. So almost 80 to 90% of effacement and 6 centimeter dilated cervix. So they were sure that if they cut the cervix, they're going to deliver a healthy baby. And of course, they did it and sutured it properly. So there was absolutely no complication, no PPH, and no sepsis as well. This is again a case where they required 3 incisions, 3 centimeter long. Hemostasis was achieved by single layer suturing, and of course the antibiotics for 48 hours, packing, and this was a patient which, because of the prolonged bearing down, the cervix was ischemic. So because of all this conservative management and packing, the cervix was also healthy later on. So the learning points here are recognition of the uterovaginal prolapse in pregnancy as a serious entity with dire consequences in the intrapartum period. I would suggest that there comes the rule for preconception counseling and the actual internal examination of the woman, if suspected, definitely should avoid allowing her to become pregnant and go for the corrective surgery beforehand. If at all she presents to you during pregnancy, then the proper advice and management has to be done to avoid further prolapse of this uterus. And of course, prompt delivery by Dewerson's incision serves as an option in case of prolapse cervix with dystocia and the fetal head outside the introitus but inside the cervix, So post-procedure hemostasis and control of the infection, they are imperative. I think this was only for the Dewerson's incision, but when we talk about Dewerson's incision, there was one more terminology which is derived from Dewerson's incision is vaginal cesarean section, and this is what is the cervicosegmental incision, the incision from the cervix which extends up to the lower uterine segment. The vaginal cesarean section, the term is very self-explanatory, not the abdominal cesarean section. So you don't have any abdominal scare here, and the patient is also happy, but it is not so simple. The technique is attributed to Chartas and it was promoted in France. This is only few situations where I would also say that if the fetus is dead or it is very small and non-salvageable, all other pharmacological agents, they don't work, and that is the reason maybe you have to go for this approach. That is what the things here they have described, that there is no abdominal scare, and also she can go for subsequent vaginal deliveries later on. So there's no question that she should not deliver vaginally. So this is what they have tried to show, the simple steps here, like vaginal hysterectomy, where you have to open the vagina, separate the bladder, retract it, and then of course you take a cervical segmental, lower segmental incision. We will not go into the details. Definitely it has its own limitations. The cephalopelvic disproportion, as I have said earlier, placenta previa, and of course this should be, if at all, done for a dead fetus or a non-salvageable fetus. Hemorrhage, tears of the incision, bladder injury, so many complications you can just think of, and of course the post-operative fistula can be a dreaded complication. So to sum up, Dewerson's incision, its role only, I feel, in the uterovaginal prolapse which presents to you as an emergency, where the head is outside the introitus and you have no option but to go for the vaginal delivery. And that is a situation where you can just give an incision on the Dewerson's, the cervix, and then you can deliver the baby. We have described the procedure as 10 o'clock and 2 o'clock position, only 2 to 3 centimeter long, a controlled incision. Because if you don't give here, maybe with further bearing down, the patient may have on her own the cervical tears, which will extend quite up, and it may extend laterally also to go into the broad ligament. So vaginal cesarean section, I don't think, I would just say it is obsolete, and we should not think in this modern obstetric, there is no place. So having said that, there is a big but. Yes, as far as possible, go by convention. Think once again that this is the only and best possible intervention at that particular moment. Think of safety of the mother and the baby as well as safety of yourself. Because what we have discussed initially, whenever you have a very severe fetal distress where you have time for the cesarean section to get arranged, but if you feel that everything is going on well, just give a nick on the cervix and you can have a healthy baby. I think that is the only time where you can use this Dewerson's incision, but see that the evidence, especially your parent organization, supports the intervention. So in modern obstetrics, only when you have no option or time to go for cesarean section. That is what the take-home message from my side. And thank you, Ranjana madam. You made me really go through all the literature. And, in spite of being a busy obstetrician for 30 years, You really give a new insight to this topic. And I thank the respected Madam Usha Sharma for her blessings. I thank all my UP friends who are here, especially I will not name, all of them are very close to my heart. And I humbly appeal for my candidature for Vice President Foxy from West Zone. I'm not working only for the elections. All of you know this. I am working for Foxy since last 20 years. 2003, I was a founder secretary of my society. And since then, I have been working for all the committees of Foxy. I have been climbing the stairs, ladder slowly higher. Being from a small society, you can understand that what hard work it requires. And I'm thankful to all of you for always loving, blessing, and appreciating me. Thank you so much. Thank you.
Thank you, ma'am, for such a lovely talk. Now I hand over the session to Dr. Jaiswal.
Thank you, Dr. Parul. Good afternoon, one and all. Thank you, Ranjana ma'am and Amita, for making part of it. I welcome all faculties of AMOGS, Meerut and Allahabad Obst and Gynae Society on board. Now we are going to our last session today, that is old perineal tear, when and how to repair. The speaker is Dr. Bharti Maheshwari. Chairpersons are Dr. Kirti Dubey. She is past president, Meerut Obst and Gynae Society. She is vice president, UPCOG. She is ex-principal cum professor, LLRM, Medical College, Meerut. She has experiences more than 35 years of teaching and research. She has many publications in her credit. She is on editorial board of Journal of UPCOG. She is invited as speakers and organizers of many national, state, and regional conferences. She is having interest in infertility and high-risk pregnancy. Thank you, ma'am. And now, next chairperson is Dr. Urvashi Bhavan Singh. She is our vice president of our own society. She is professor and head Department of Obst and Gynae, United Institute of Medical Sciences, Prayagraj. She has received many awards in her credit, like Begum Fatima Kalbi, Abbas Gold Medal for Best Publication in Journal of UPCOG 2015, awarded Best Paper Presentation in UPCOG 2016. She has having many publications, around 18, 11 in state, 8 national and 9 international journal. She is treasurer of UPCOG 2018, life member UPCOG, IMA, IMS, AIDS Society. She is peer reviewer of JAMR, Asian Journal of Pregnancy and Childbirth. She is presently, like I said, she is VP of our society. Thank you, ma'am. Now I request Dr. Urvashi, ma'am, to introduce our speaker.
Thank you, Uma, for your nice words. Good evening to all. I want to give thanks to organizer Dr. Ranjana Khanna and Dr. Amita Tripathi for making me part of this program to chair the important session, very important topic, perineal tear. Everybody, all of us have encountered perineal tear in their practice. And the incidence of perineal tear is 0.5 to 2%. And obstetric emergency is most common cause of sphincteric injury and perineal injury. Pudendal nerve injury may take place because of the prolonged second stage of the labor. To tell about this, we have Professor Bharti Maheshwari. She's a known face in Foxy. She's my friend. She's professor and head of the Department of Obst and Gynae, Muzaffarnagar Medical College. She's diploma in IVF and reproductive medicine from Germany. Chairperson Foxy MTP Society between 2018 to 2020. Fellowship in Medical Education by MCI FIME. Governing Council Council member, ICOG. She's Secretary, UPCOG, President, Meerut Obst and Gynae Society, author and editor of many textbooks of Obst and Gynae, published paper and reviewer of articles. She delivered Kamini Rao oration and other talks in national and international conferences, organized North Zone and UPCOG conferences as organizing secretary, national coordinator for MTT Committee 2015 to 18, executive member Endocrinology Committee, Public Awareness Committee, and Medical Education Committee. So she has gone through so many important roles in FOXY. So I will welcome Dr. Bharti to come and share your few words regarding the old perineal tear, when and how.
And I would also like to request everyone to vote and support for Dr. Bharti Maheshwari as she is contesting for the post of Vice President from our North Zone.
Thank you very much, and good evening all. And it's really a great opportunity to meet all of you, and really thankful by heart to Dr. Ranjana Khanna madam. She is always supportive and so affectionate by heart to every one of us from North Shore, and to me always. And pranam to our Padmashri, Dr. Usha Sharma madam, Rajendrasing Pardeshi sir, Dr. Kirti madam, as well as many senior teachers here, and dear Dr. Urvashi, Dr. Chitra, Dr. Amita, Dr. Uma Jaiswal, Dr. Parul, and Dr. Kenan is of course not here, Dr. Sneha, Dr. Komal, and Dr. Varsha. Thank you for this opportunity. And in next 15 to 20 minutes, I am just covering the topic that is last but not least. And Dr. Ranjana Khanna has made very beautiful scientific program. I think it is very useful for all young, all postgraduates, and every one of us. By that, we can reduce, in fact, the incidence of cesarean sections, and we can learn the art of normal delivery. So the bad part, and one that we can say that unpleasant consequence, that is perineal tear. So the topic is given to me that when old perineal tear comes to you, how you have to approach and when. So I am just next, yeah. So perineal tear, we all know that lacerations of perineum, they are the results of overstretching or too rapid stretching of the tissues, especially if they are poorly extensile and rigid. So perineal injuries are more common in primary because of rigidity of the perineum. And before going to in details about the management of the perineal tear, one has to know some ideas, or one has to revise about the female perineal muscle. And you can see in this diagram that you can see from perineal body and the back from the sacrum to coccyx, and then coccyx to rectum, and then you can see vagina, urethra, and all of surrounding muscles like levator and eye muscle, which is a very important muscle, puborectalis, iliococcygeus, and then you can see this is the whole fascia, and then we have a ischial spine, and this is the coccyx and ischiococcygis muscles, as well as piriformis muscle. So these are the different muscles, and that is they can tear or they can have some injuries during the delivery. COG classification of perineal tear, that says that the perineal tear could be of first degree when there is an injury to perineal skin only, second degree when there is an injury to perineum involving perineal muscles but not involving the anal sphincter, third degree when injury to perineum involving the anal sphincter complex. And here, if less than 50% of external anal sphincter thickness is torn, then it is 3A. 3B when more than 50% of ES thickness torn, and 3C when both ES and internal sphincter torn. 4th degree when injury to perineum involving the anal sphincter complex, both external and internal, and anal epithelium. So this should be very much clear to us. And this is, you can see by the diagram, you can just have an understanding that this is the first degree tear where only the involved the tertiary perineal skin and vaginal mucous membrane. This is the second degree where you have the involved the addition of fascia and muscles of perineal body, but not the anal sphincter. And beside that, third degree perineal tear extend farther to involve the anal sphincter, external anal sphincter tear, and in the fourth degree where extend through the rectum mucosa to expose its lumen. So by this pictorial orientation, you can have an idea of the type of perineal tear, and then you can proceed for the management. Obstetrical anal sphincter injuries. They are complications that occur during vaginal delivery. They referred as 3rd and 4th degree perineal lacerations and involve the anal sphincter complex and in more severe cases anal mucosa. And they contribute to short-term morbidity such as wound breakdown and perineal pain. And OSS is a leading risk factor for subsequent loss of bowel control in the woman. So if we see the risk, then overall risk is 6.3%, risk of OSS in the first delivery 5.7%, and risk in Paris women with no previous history, then it is 1.5%. The risk factors, they could be obstetrical and non-obstetrical. We all know obstetric causes malpresentation such as breach, contracted pelvic outlet, prolonged labor, operative vaginal deliveries, forceps or vacuums, macrosomic baby, occipitoposterior deliveries, precipitate labor, epidural analgesia, induction of labor, rigid perineum. So this is the important thing, that when such cases are there, we have to keep in our mind to for the chances of such type of injuries. And the important thing is that one has to identify it early so that it can be repaired in the 24 hours. But unfortunately, if sometimes they are not identified,
please.
Or sometimes it is wrongly identified and their incomplete repair is done, then they can lead to old tears. Non-obstetrical causes, rape, fall or accidental injuries, etc. Screening at time of vaginal delivery, no consensus as to whether or not postpartum women, they should be routinely screened for OSS in the delivery room or postpartum period. Persistent pelvic floor issue in the postpartum patients, fecal urgency or incontinence should raise suspicion for possible pelvic floor injury, including OSS. Risk reduction, they can be by the, of course, Ritgen maneuver, where delivery of fetus should be conducted properly with delivery of head in controlled manner by Ritgen maneuver, which is promoting flexion of head with left hand and giving support to perineum with right hand. So this is a very basic step which we are taught when we just learn to do the vaginal delivery, that maintain the flexions, keep proper perineal pressure and all. And then of course episiotomy, perineal massage or heat. Maternal birth position, increased injury of women who deliver in a standing, squatting or lithotomy position is observed when compared with when women deliver in the supine, semi-recumbent or lateral recumbent position. Obstetric provider trainings, it is also important to prevent these such type of injuries, because to improve clinician understanding of perineal anatomy, improve recognition of obstetrical laceration, and they reduces the OSS. So that's why nowadays there is lots of skill training, lots of module training. They are available in the postgraduate teaching institutes as well as different workshops and all. Clinical presentations, the moment they can present when they have some injuries, like most common presentation following vaginal delivery. Immediately, diagnosis is confirmed by physical examination, including anorectal examination. And postpartum women, it refers to anal sphincter injury during postpartum period, typically with 6 to 8 weeks after delivery, but they are not recognized at time of delivery. Symptoms, say perineal pain or discomfort, bleeding, perineal bleeding or discharge, and loss of bowel control. Delayed, the woman can have a OSS, the injury of anal sphincter, they refers to anal sphincter laceration, and they are diagnosed beyond the postpartum period, generally remote from the delivery, and the woman typically present with symptom of loss of bowel control or fecal urgency years following delivery. Anal sphincter injury not recognized on examination after vaginal delivery, and thus unrepaired, or recognized and repaired but with continued sphincter defect. Up to 35% of women with recognized and repaired OSS will have persistent sonographic defect of the anal sphincter complex 6 to 12 months postpartum. So means that even just after delivery, you are expert and you are knowing everything, and even you just have suspicion or you are repairing it, but most of the time it remains not completely repaired just after delivery, and in the ultrasound you can see the persistent defects in the sphincter complex. History components for women with suspected obstetric and sphincter injuries immediately following deliveries, they all important, and especially all such type of consequences mainly also depends on the duration of the second stage of labor, infant birth weight, obstetrical laceration and degree if known, use of episiotomy and extension if known, use of forceps or vacuum. Additional obstetric information one must have when woman is having some vaginal delivery and such type of complaint, that like the patient have an obstetric lacerations, is it repaired at the time of delivery, or do you have problem with perineal healing, will have a woman's wound separation or infection, and any treatment she have received, any history of prior pelvic surgeries, prior rectal surgeries. So these questions has to be asked. And beside that, for the GIT symptoms, one has to rule out other GIT issues also like inflammatory bowel disorder, and one has to ask for the bowel function history, frequency of bowel movements, need to strain or defecate, difficulty with evacuation, regular stool consistency, chronic diarrhea, fecal urgency, such type of thing. All regularly used medications, one has to be taken having a history like for the use softener, laxative, etc. And examinations, general condition, vital pulse, pallor, jaundice, respiratory, urine output. Besides that, on the pelvic examination, amount and site of bleeding, degree of perineal tear, per speculum examination, bleeding from other sides, cervix or vagina, amount of damage of anal sphincter. This is very important. Involvement of rectal mucosa, presence of necrotic tissue or slough. So both by the pelvic examination as well as per rectal examination. By PV, you can confirm the perispeculum finding as well as uterus size, whether it is contracted or not, levator and eye tone. This is very important examination what you can do on the PV. As well as by the per rectal examination for rectal prolapse and grip of sphincter. So this is very important, and in our around 10-20 years back when we were in the residency, so we have seen many cases. Of course, now incidence is decreased, but still we have certain cases. Cardiovascular and respiratory system, abdominal examination, condition of torn tissue to decide immediate or after repair. Now this is the picture here. You can see occult anal sphincter injury suggested by Dovetail sign or physical examination. Here you can see the absence of anal folds along the perineal aspect of the sphincter. This suggests that external anal sphincter at least partially separated. Here you can see that loss of anal folds on the side of the anal sphincter. Investigations, transperineal ultrasound, 3D ultrasound. This is a picture of ultrasound where you can see very clearly picture of external anal sphincter as well as internal. And here MRI or stool examination for cyst or ova, they are also helpful to decide the extent of injury. It is confirmed by imaging, typically endo-anal ultrasound that demonstrates torn anal sphincter complex. Here you can see. And beside that, endo-anal ultrasound evaluate the entire anal sphincter complex, including both internal anal sphincter and external anal sphincters. The thin, this you can identify, you can the internal anal sphincter which is hypoechoic dark, and here this arrow they identify the mixed echogenicity, that is the external anal sphincter. So by ultrasound you can have a very definite diagnosis that what is the degree of the injury. Pre-operative evaluation. Experience of patient shift to operation theatre for exploration and repair the tear under general anesthesia. Consent of the woman has to be taken. Examine the vagina, cervix, perineum, rectum properly. Repair the rectum mucosa using interrupted sutures 3040 or 0.5 centimeter apart. RCOG guidelines support the use of a single dose of antibiotic as well as to reduce the third and fourth degree of laceration. One has to use the proper infection prevention. Treatment, recent tear repaired immediately following delivery of placenta, delayed beyond 24 hours, then immediate repair in the second degree with antibiotic coverage. You can do that. Clinician's personal review is important. Then complete tear should be repaired after 3 months if delayed beyond for 24 hours. Otherwise, it would not be completely sutured. And then again, you have to do the procedure. Repair of recent complete perineal tears within 24 hours. Patient is that is all aseptic precaution has to be taken, and suture material is 10 Vicryl or chromic catgut. They can use by end-to-end or by overlapping surgery. And end-to-end, the cut end of the external anal sphincters, they are isolated and brought to the midline, and the transverse incision at vaginal and anal mucosa. Here you can see that the transverse incision at vaginal and anal mucosa, and then ends of EAs are identified, external anal sphincter, and then anal IAs are also seen, that is the white fibrous tissue between the anorectal mucosa and external sphincter. Anal mucosa closed with 20 Vicryl and IAs closed over anal mucosa. Suture with 20 Vicryl and internal anal sphincter closed over anal mucosa with 20. End of EAs are mobilized and brought over sutured IAs. So, and suture together with 2 rows of delayed absorbable 10 Vicryl. So by this way, you can sphincter repair can be done, incision and end-to-end approximation. Both the sphincter are stitched end-to-end technique. Levator and eye muscles are brought together with interrupted delayed absorbable Vicryl suture, and bulbocavernous and superficial transverse perineal close with 10, vagina mucosa close with 10 or 20, or perineal skin close with 10 or 20 Vicryl as interrupted suture. And here, this is the overlapping technique. Here, the inverted V-shaped incision. This is the here the inverted V-shaped incision is done, and flap of vaginal mucosa dissected free from above downward and turned downward, and then they are done by the approximation is done by the overlapping technique. Levator and muscle sutured over ES into by one Vikrin, and vaginal mucosa closed with continuous 1-0 delayed absorber suture, and perineophraphy performed by suturing bulbocavernous superficial transverse and perineal skin as we do in the episiotomy. So basically this is the repair. You can see the lacerated perineum before repair as the whole tear. You can see that the sphincter is also lost. Then closure of rectal mucosa first with running suture. Then closure of endopelvic fascia with interrupted suture. And then closure of anal sphincter with interrupted suture. Closure of perineal muscles with interrupted suture followed by subcutaneous tissue of perineum reapproximated, and then subcuticle closure of skin. So by these steps you can just have an orientation for repair of lacerated perineum. Post-operative care, of course, for first 24 to 48 hours, woman has to be nil orally, and then all women should be fully explained on the day after repair. Antibiotics has to be covered. Avoid anemia and rectal examination for 2 weeks, and screw softener laxatives can be given. Post-operatively, the very important thing is that physiotherapy and pelvic floor exercises for 6 to 12 weeks. Stitch bar having a very important role for the proper healing. Discharge advice, women should be discharged on 6 or 7 days with 6-week follow-up is essential. Clean perineum after urination, contraception advice, reassess after 6 weeks, and then see for the any residual disease. What complication one can have again after this laceration if it is not complete: incontinence of a stool or flutters or hematoma or rectovaginal fistula, fear, difficulty and discomfort in passing a stool. Besides that, sometimes there is the woman is having the symptoms like fecal agency, pain, dyspareunia, failure of repair requiring secondary repair, wound infections or delivery by cesarean section in future pregnancies. So this was about the perineal tear, and that is when old perineal tear, when and how it has to be repaired. The thing is that first identification of perineal lacerations and their immediate treatment, they are very important. So prevention of occurrence of old total perineal rupture, because this not only decrease the quality of woman life, beside that they also have lots of inconvenience to the woman, and it is a bad discouraging part for the normal vaginal delivery. Beside that, management with the overlapping sphincteroplasty and perineophraphy, it is an effective technique to correct this condition. Thank you very much, and thank you for giving me this opportunity. And again, by folded hands, I request all of you that as you have given me lots of support, lots of affection, my MTP committee tenure, I request all of you to support me for the North Zone Vice President in by e-voting in coming 1st to 10th August. Thank you very much.
Thank you, Bharti ma'am. Such a elaborate talk. We usually come across when delivery was taken care by untrained personnel. So timely, just as you said, timely treatment, identification and closure or treat the laceration and tear completely. Thank you, ma'am. I request Kirti ma'am to give your inputs.
Oh, hello, Ranjana. Thank you so much. Amita, thank you very much for making me a part of this webinar. And it was a lovely obstetrics session which I've had today. And Bharti has made a real full presentation. Bharti, you've really did so well. It would have been nice if this lecture would have been for undergraduates and postgraduates. Well-prepared class, I would say.
Very nice lecture.
And actually what was, I thought that she would be only talking of how we would deal old perineal tears, because we, especially in UP, where the women are handled so badly in the rural places, they have complete perineal tears, 4th degree. They do not come immediately. They would come to you after years when the life has been really hell. And what I have actually gathered from the past years, that this is a surgery which really gives real applause from the patient when you do it so well. And basically it is how you are preparing your patient. That is more important. And we have not been taking help of these investigations like an ultrasound or an MRI or whatnot. It is just a clinical examination which tells us. And a selection of patient, what is important have to see the cervical pathology too. If the woman has a very bad cervix, a very bad erosion, a very bad vaginitis, your complete perineal tear would never heal. So you have to make a pre-op evaluation of your patient. You have to do a pre-operative preparation of an old perineal tear. You'll have to prepare bowel. It is not an obstetric tear which is at that very moment. It is an old tear. You have to prepare the bowel by metronidazole, by neomycin or Norflox, whatever you give her. And then you have to separate the layers of the vagina, of the anal mucosa, stitch your anal mucosa. Now, of course, we are doing it with a continuous suture. Initially, when we were taught, we were taught off and the knots inside. You know, that's quite cumbersome. Now we are doing it with acryl. And we have to not label it as an internal sphincter. It is just the fascia. We do it before we do the external anal sphincter. That is the internal anal sphincter, with which they call it, which they labeled it by the color of the fascia, which we recognize. And if done properly and post-op done properly and managed, of course, I restrict the bowel movement for 24 hours. I even put in a flatus tube so that the flat covered it so well. And I would love my postgraduates to see them. I would love to see them doing this. It is a really very, what I would say, it really gives applause to the surgeon who does it.
Thank you, madam. And really, I am blessed that you are here as my chairperson as well as guide, and you have given very valuable comment, because these things, I agree that what experience very much matters, because you have seen such cases repaired and then. So this is very important, that how pre-operative evaluation, preparation, bowel preparation, this is really most important step.
Yeah. I just want to say one thing, Amita.
Yes, Dr.
Congratulations, Dr. Bharti. Very nicely you explained. I just want to share one of my case of perineal tear. I think 7-8 years back in the medical college, a small girl came, 3.5-year-old only. She came after the rape with complete perineal tear. So we stitched that within 24 hours. She came after, I remember 14, that was 15th August day, holiday day. We went to Pura Bada Oti Khul Gaya uske liye, and we stitched with all microsurgical instruments, and the girl then well after that.
Dr. Urvashi, medical colleges, we often see these rape cases of traumatic perineal tears. And of course, these girls, though they come late because of the all police information and all that, what we need to do is we have to cut that necrotic tissue, because they come usually late, 24 hours, 48 hours, and we repair it. And one thing I would like to share over here, you please wash the lower bowel with a betadine solution when you are stitching these perineal tears of after rape. And they also go very well. I've seen surgeons doing a colostomy for them, and they ask that girls would be repaired after 6 weeks. That's wrong. For gynecologists, you should do it. You should do it even if the girl has come late. Repair. Because there's so much of, I would say, so much of mental trauma to them if you leave them like that.
Of course.
And ma'am, one more thing to add, ma'am. Kirti ma'am will remember that case. Ma'am, at times the tears cannot be approximated. So we need to take the help of some plastic surgeons for grafts also. They are also very specialized in all these cases. Yes.
I can see there are no question in the question box, and I think all the lectures are wonderful. So there is no query inside the delegates. So we have come to the end of the session, and I want to thank all the societies, AMOGS, Meerut, and Allahabad for holding our hands. I want to thank ICOG office for always granting us point, and this time they gave us 3 points. My utmost gratitude to our chief guest, Padmashri Dr. Usha Sharma ma'am. Your blessings and presence were very precious for us. और आपके साथ जब भी रहते हैं तो ऐसा लगता है कि गुरु की छाया में बैठे हुए हैं. Thank you, ma'am, for being here with us. I want to special thanks to our guest of honor, Dr. Rajendrasing Pardeshi sir, for your wholehearted support and words of blessings. I can't thank enough our chairpersons, Dr. Ranjana Khanna ma'am, Dr. Kirti ma'am, Dr. Kiran Kotkoti, Dr. Sujata, Dr. Chitra, Dr. Ashna Goyal, for your support, and Dr. Urvashi for your support and your inputs. My heartfelt gratitude to all the speakers, Dr. Varsha Baste, Dr. Komal, Dr. Sneha, Dr. Bharti. You all are stars and pride of Foxy. You have taken Foxy to the new horizon and you will take in future. That I know. You all are my best wishes to all of you. And thank you. All the talks are wonderful and we enjoyed a lot and learned a lot. Thank you, Dr. Uma and Dr. Parul, for helping me. And thank you all the delegates for joining with us. Thank you, Jagsonpal.
Especially Deepika.
And Amit also.
For troubling all the time.
हमेशा हम लोग बस केवल बताना होता है और हमारा काम पूरा हो जाता है, कोई भी problem नहीं होता है. Thank you so much. Thank you everyone for joining the great number.
Thank you. Just like to take this opportunity and showcase a few of our brands which have micronized dydrogesterone 10 mg tablets as Divatrone, which has also won the Excellence Award last year.
And the first runner-up is Divatrone from Jagsonpal.
Then we have our injection Maintane 500 and 250 mg. Divagest, all the range of natural micronized progesterone available as sustained release 200 and 300 mg tablets, and also vaginal soft gels of 200 mg. Injection of progesterone as Divagest 100 mg. So looking forward to the support to all the progestins that Jagsonpal has to offer. We also have beside this norethistron control release tablets as Cycloreg CR10 and Cycloreg plain 5 mg. And we have Endoreg, our Dynogest 2 mg tablets. So thank you very much.